Yeah, I really enjoyed the SOHO meeting, and in particular, the next question section where experts were asked to comment on where they thought the field was going was very interesting to me because there was so much really harmonization across many, many different diseases as far as where the field may be going in the future. Specifically in Hodgkin lymphoma, I brought up two areas that I thought we needed to think about in the future. One is that over the last year or so, we've appreciated that Hodgkin lymphoma molecularly is a heterogeneous disease. There are several subtypes of Hodgkin lymphoma. Depending on different categorizations, you can divide it into either two or three different subtypes. And I asked the question whether those subtypes ultimately may inform treatment in a precision way. For example, there are data that suggest that we've presented with the nivolumab-AVD regimen having significantly improved outcomes in EBV-positive patients. Those patients who have EBV in their Hodgkin lymphoma probably fall into the virally driven Hodgkin lymphoma subtype through molecular classification. And it may be that checkpoint inhibitors are perhaps very important to use for that subtype. So, although I think it's certainly appealing to think about studies in the future that could have a precision approach, at this point, I think it's unlikely to have widespread use, not only because the assays need to be refined, but also because the outcomes that we're seeing with nivolumab-AVD are so good across all subtypes. But I think it's important for the audience to understand we appreciate now they have these different subtypes and that we're going to be seeing more and more data come out about them. The other area that I discussed as far as a future direction was whether we could use the nivolumab-AVD regimen in early stage Hodgkin lymphoma. All the data that is randomized has been in advanced stage disease, but early stage disease is the most common presentation of Hodgkin lymphoma. And the current intergroup trial still uses bleomycin and still uses PET staging as part of response adaptation. And the question is whether we're perhaps ready to move a bit beyond those techniques for checkpoint blockade as part of standard treatment. I did present a couple of trials that are in the literature. The Germans have done a trial of 4 cycles of NAVD followed by involved site radiation therapy with amazing outcomes, almost no events. And there are a couple of small institutional trials from Seattle and Northwestern, both of which also show very favorable outcomes without radiation therapy. So I think that the field needs to consolidate all this information, but I think for many patients, it certainly is a consideration today to take the advanced stage regimen and start using it up front.